Their preliminary stent boost, but I don't think it is as nice as the one you see in Philips.
But the stent boost is really, it's really nice. And to be honest, we are not doing IVUS to assess all the procedure because again, for financial constraint. And but we use a stent boost in routine practice, as you can see here, 3, 4, 5 times during the procedure. And it's particularly nice when you are doing bifurcation with the tap, or another definition of the tap, strategy. And this is interesting because with the stent boost you can see very well the two stent, the protrusion of the stent, etc. Sometimes you have some artifact when you have 2 wires or 2 stents, but if you repeat, you will find some a view without artifact. The other point is when you want to overlap 2 stents. Sometimes it's difficult, particularly in a calcified lesion. We saw on the previous case. If you use the stent boost, you will see very well the zone of overlap between 2 stents. And if it's too much, we have to pull back a little bit of the stent, redo the stent boost, and we do this really several times during the procedure.
So you mean that it compensates against IVUS? You mean?
It's a sort of compensation. It's the IVUS of the poor,
IVUS-like
poor
picture.
man. Yes, it's a sort of compensation. But it's really useful. Of course, it shows you that your struts are parallel, particularly if you do this in 2 orthogonal views and do 2 times the stent boost, you can see that the struts are parallel on this view, parallel on this view. You can believe that the stent is correctly deployed. It is not IVUS. You cannot see, of course, if there is any malapposition between the wall and the struts, but you can confirm that your struts are parallel, and this is not too bad.
Can I give you an idea for Philips to offer FFR machine with a stent boost in order to have all the complete cath lab?
This is another question.
Either if we are finished or not the procedure.
Should we give some nitro? Pressure
is correct. Okay.
Yep.
Result of the stent seems okay. There is no dissection beyond or before the stent. We'll check now in the LAO view.
Yeah, it's a beautiful result, and geographically it's a beautiful result.
You can zoom just on the spot.
The flow on the diagonal is very good. Yes. And geographically there is no significant changes between the pre and the post procedure on the diagonal.
So I will remove the 2 wire and do the final control and geography.
Very nice.
Very nice.
It's very good because when you look on the screen, the baseline angiography, particularly on the diagonal, you can see that there is absolutely no change, particularly at the site of the ostium of the diagonal. There is absolutely no pinch, no carena, no shift of the carena. So it's a great. It's a great result. So, Marty, you can summarize this interesting case.
So I think it's interesting how our treatment of patients has changed. I mean, I think some years ago this patient would have ended up with at least 4 or 5 stents in. Presents with an unstable syndrome. The right coronary is dealt with. We then come back to the left coronary system, which superficially looks like 3-vessel disease, including a very major diagonal. I think use of FFR to demonstrate that the circumflex didn't need treatment is important. And then to some extent, the FFR was able to guide our treatment of the bifurcation pre-procedurally. And I think what could have been a very complicated V-stent type of approach was turned into a straightforward, although very beautifully delivered stent, very accurately delivered stent, into a much more straightforward procedure. And this patient should do very well. I think it's a very nice demonstration of physiological guidance of coronary intervention.
Thank you, Bruno. Thank you, Martin. And again, Martin, thank you very much for...
Okay, so this is the end of the case. I suppose there is some question. It's quite provocative. I'm sure that the majority of you will treat the diagonal and with the LED. And this is, we have chosen this case. We have recorded a lot of cases for this live in the box. And we have chosen because the first case was really a technical case with rotoblator, long calcified lesion. This case was totally different. It was the concept of the functional evaluation, and the functional evaluation will guide the PCI procedure. So it's a little bit provocative, I'm sure of that. Personally, when I saw the film the first time, I say we were discussing how many stents, what will be the strategy or the double stent technique. And in fact, and if we believe in FFR, we have to follow this conclusion. The patient could be treated very simply with a single stent of the left coronary system. Maybe 2-3 years ago, this patient will receive 2 stents on the LED diagonal plus 1 in the left circumflex artery. So it's interesting case. We have now to follow this patient and very carefully. The follow-up of this patient will be given during the EuroPCR this year. So we did the case in November. It should be 6 months later. It's a shorter, of course, follow-up. But we have to follow this kind of patient very carefully, because what is true at 1 year could be by fame, or 2 years could be different in the long-term follow-up. So we have to follow this patient carefully. But it's interesting because it's really a different way of reasoning when we have this kind of patient with multivessel disease. Any comment? Yes, 1 and 2. Yeah.
Since the strategy we have used is to stent the LAD just after the diagonal, do you think there's any need to rewire that diagonal, given the fact that there is a plaque and physiologically is not significant by FFR, but there is a plaque? So putting a wire there, we have put already FFR wire, another wire, and we are not stenting across that diagonal. Do you think there is a need for that wire to be placed in that diagonal, and
No.
there is that chance of converting it from stable plaque to unstable plaque?
That's true. It's a good point, and we discussed this when we have done, I remember, this procedure. The positive point of placing a wire in a diagonal is that if for any reason the stent is placed proximally, cover the osteum, you will get the wire in protection. It could be positive because it changes the angle. It could facilitate the recrossing of the strut if the stent is placed, the LED stent is placed too proximal, covering the osteum. The negative point, and you are right, is that placing the wire, you could do a dissection. You can place the wire under the plaque, subintimal, and create a dissection, because this is not a normal artery, it's the disease artery with a significant lesion. And so when you do this, you have really to manipulate the wire very slowly and carefully, and choosing a very soft wire, and then choose an hydrophilic or stiff wire for these kind of things. Yeah. But you're right, there is a positive and a negative point. And this procedure could be done with the single wire technique, absolutely. Yep.
Regarding FFR, I think now give a new tool to diagnostic what the significant physiological for this lesion. it's mean we will do just less stent. If you do less stent, it's mean for the MACE, it's less for this patient. I think it's good modality to evaluate the lesion than other modality. Thank you very much for you.
Yes, I think it's, the FFR is a good modality, and Ibrahim, Mohammed, or Hassan, you can answer to this question. It's a good modality. There is a good correlation, again, with the result of FFR and the clinical outcome. This now is proved since 2-3 years. Again, we need a longer follow-up in order to be sure that what is right at 1 or 2 years is still right at the longer follow-up. We don't know today. We don't know. But it's true that at 1 or 2 years, the use of FFR first gives you more simple procedure, less number of stents implanted for a similar clinical outcome. And this is fine.
I think I've noticed.
There is another question there.
Yes, please go ahead.
And Ibrahim, you can answer to the question. Go on.
I would like to, be a little bit pessimistic here. This was done in a simple way, and there was no plaque shift. This diagonal branch angiographically, at least to me, looks, with not ostial but proximal significant lesion. I don't know how fraction flow reserve was insignificant here. Angiographically, this diagonal has a proximal significant lesion for me. But suppose that there is no significant lesion, but you put a stent there, and there is a plaque shift to this diagonal and the proximal part of the LAD, proximal to the diagonal. What would be the scenario in this situation? What you would do?
Ibrahim, you want to
That's totally, I would, to tell you the truth, if I had seen this patient as a second opinion, and I haven't seen that this patient had an FFR done, I would think that was not a good result at the end. But if I read that the operator, without knowing it was done in Toulouse with your colleague, if I have seen this person have done an FFR and had decided correctly that to leave that diagonal, I will feel satisfied, to tell you the truth, But because sometimes what we do as we get a lot of second opinions, and you get a CD by a patient, and you see it's something like this, you would call this not a good result at the end. I agree with you. But having known that he has done an FFR, you cannot have any, you cannot argue against that, because it is driven by FFR, and we do that. Now, your second question was, now you've done FFR, and it was not significant, but then you position the stent, be it after the diagonal or prior to the diagonal, and then there was a plaque shift, then you go to square zero, because you don't know what happened to the diagonal. Maybe the plaque shift was so significant that the FFR would change. Because as you know, sometimes you put the stent across the diagonal and it occludes completely, and you have clinical chest pain, ST segment shift, and next day you would have some enzyme elevation also. So, you go to square zero, you have to, if the plaque shift is significant, you go address the diagonal and resolve the issue, be it with one stent or two stents.
My point is, would it have been better to cover the proximal part of the LAD with a stent? To start stenting from proximal to the LAD to distal to the, proximal to the leg.